nombre de TecSalud del Tecnológico de Monterrey, les damos la más cordial bienvenida a la primera sesión de Gigantes de la Medicina 2018, con nuestro invitado del día de hoy, el doctor Jeffrey Weitzel. Les deseamos a todos los aquí presentes y a las personas que nos ven a través de Facebook Live que este año que inicia esté lleno de proyectos, logros y grandes satisfacciones. Para dar comienzo a esta sesión, quiero ceder el micrófono al doctor Manuel Pérez Jiménez, decano de la región norte de la Escuela de Medicina y Ciencias de la Salud, para que nos presente a nuestro invitado especial.
Buenas tardes a todos. Muy feliz año para todos. Por ahí mis estudiantes, algunos dicen que ya no me reconocen, pero bueno, ya no soy más de canas, ¿verdad? La verdad estamos muy contentos de iniciar el año con pues, el primer día de las clases de los muchachos de semestres, y obviamente para los de clínicas pues ya llevan un poquito más de trabajo y los residentes pues no paran, pero estamos contentos con iniciar el año con la sesión de Gigantes de la Medicina. Hoy tenemos un primer invitado que gracias a la doctora Cinta Villarreal que nos acompaña aquí pudimos hacer el contacto y tenerlo con nosotros y aprovechar la visita del doctor Wetzel, el jefe, como él dice. Voy a leerles una breve reseña de su trayectoria para poder introducir la sesión y así darle oportunidad a nuestro rector, el doctor Torre, para que haga su entrevista. El doctor Jeffrey Wetzel es egresado de la Facultad de Medicina de la Universidad de Minnesota, director de la División de Genética en el Centro de Genética Clínica y el Departamento de Ciencias de la Población. Es director de la Red de Programas de Detección y Prevención del Cáncer, así como director del Programa de Educación Genética del Cáncer. Está certificado por el Consejo de Oncología Médica y Genética Clínica. Es miembro de la Sociedad Estadounidense de Oncología Clínica y del Comité Nacional de Guías Genéticas de Comprensión y Evaluación de Riesgos Familiares. Sus programas multidisciplinarios clínicos de investigación y entrenamiento enfatizan la investigación translacional en la evaluación del riesgo genético del cáncer, la quimioprevención, la terapia dirigida a resultados clínicos y psicosociales, la epidemiología genética y la investigación de servicios de salud en minorías marginadas y cáncer hereditario en hispanos. El doctor Weitzel ha realizado investigaciones sobre prevención, nuevos métodos y aplicaciones para la detección temprana de cáncer o pruebas genómicas predictivas, así como la influencia de factores sociales, cognitivos y culturales asociados al cáncer. Ha establecido un equipo de investigación con socios bilingües y biculturales, así como entrenadores y consejeros en genética, lo cual refleja la relación colaborativa de sus diferentes entornos, y ha trabajado para contribuir y desarrollar herramientas genómicas en materia financiera y económicas para la evaluación del riesgo genético del cáncer mismo. El doctor Jeffrey Weitzel es profesor clínico de medicina preventiva en la Escuela de Medicina de la Universidad de Southern California en Los Ángeles y profesor de oncología y ciencias de la población en City of Hope National Medical Center y de la División de Medicina Molecular en Beckman Research Institute en Duarte, California. Dr. Weitzel, it's an honor for us to having you here. Thank you to you and your team for being with us in Monterrey, and thank you, Doctora Villarreal, for bringing us Dr. Weitzel. Please join us in this set. Y bueno, como siempre, pues el doctor Torre, nuestro rector, hará el formato de presentación de Gigantes de la Medicina. Gracias.
Gracias, Manuel. Gracias, Manuel. So I just for full disclosure, I had the opportunity to just meet with him earlier. I did not have ample time to discuss with Jeff many of the things that we're going to address today, but I'm going to start just by asking you if you can just share with us, how was you growing up in Minnesota and why you choose medicine? What made you decide to go into medicine? Minnesota, I've been in Minnesota in the winter and in the summer, and there is no comparison. I think the winter is not a very nice place.
No, it's very cold, and it's cold right now, but you know, in both weeks of summer are wonderful. But
yeah.
But so I grew up in Minnesota, and probably my first inspiration was the fact that my mother was a nurse. I was actually the first person in my family to go to college. And so I was inspired by my mother. I did a science fair project as a 6th grader, which was, what is a red cell and where does it travel? So I didn't know then that I was going to be a doctor, but clearly there was something going on that preempted that. I worked in a hospital laboratory, Abbott Northwestern Hospital in Minneapolis, while I was an undergraduate studying microbiology. But I was running the computers for the laboratory, doing the reports and running them to each of the wards, so starting to get some exposure. And then one day the man who does the autopsies, helps with the autopsies, the diener, came to me and he said, I need somebody to do this for me on 1 weekend a month, because that's when I get paid, and basically they don't see him because he goes and buys alcohol and he doesn't come back again. But I said, why not? I'll try this. I want to see if I'm ready to consider medicine. So I did what was probably the most fascinating thing, which was I helped with autopsies. And I would go on call, and I'm with the smartest people in the world, the pathologists, right? So the surgeons do a lot. The internal medicine specialists know everything, but the pathologists know everything and do everything just too late. So in any event, I got a chance to do that with them, and it was fascinating. I then got into medical school, and I was actually a little bit bored with gross anatomy because I had been at the real thing. And so, but as they say, history helps. So I did internal medicine, and I then I thought I was going to be a bone marrow transplanter. Why? Because you go with the experiences that you have, the strengths where you grow up. So University of Minnesota is a very strong center for bone marrow transplantation.
Actually, it was a very powerful center for transplantation in general.
Yeah, oh,
I
absolutely.
remember the Department of Surgery I remember from way back then, Sutherland and Najarian, that were very, very prominent surgeons.
That's right. Dr. Najarian for kidney, and then for heart as well, one of the transplant centers of the world.
They had, by the way, because I was fascinated by that when I was here as a med student, they had an MD PhD program, and I guess maybe most of the people that did surgery needed to get a PhD. That's something that I remember, and I never forgot that about the University of Minnesota.
So despite the fact that Minnesota is somewhat inhospitable with weather, I didn't know till I left there how good the training was. So an outstanding medical school, outstanding professors, and they were there because they love science. They weren't there for the weather.
No, that's so medicine in Minnesota, did that make you, when you finished med school, you already knew that you were going to do medicine? No surgery, no pathology, nothing else, just medicine.
That's right, and I wanted to take care of adults, so it wasn't going to be pediatrics either. I like the ability to negotiate, to talk to people, and children, I think they don't always understand what's happening to them. It's incredibly, I have such admiration for those who can have that compassion and help to take care of them. But I thought I was going to be a bone marrow transplanter because of my experiences on the bone marrow transplant ward. It was dramatic. It was life and death every day, and extreme, extreme medicine. I mean, people are on the edge every day. And so I went to London. I wanted to show that I was interested in research. And my hematology oncology fellowship I had chosen at Tufts University, I committed to go and work in London at a bone marrow transplant center. So I did a volunteer fellowship. I went there, and I spent...
So that was what time?
That was in I hate to give it a year, but 1986.
Roughly, you can...
That's okay, 1986, I went there, and I worked for 6 months. And in fact, my brother, who was a garage mechanic, criticized me. He said, I can't believe that you were finally earning money, and then you quit and worked for free for 6 months. And so, because I had worked in emergency rooms and things to pay my way so that I could go and do this fellowship.
So why did you go to London at that time in 1986 in the U.S.? Because I'm going to sound that I'm too Texan, but
Sure.
But MD Anderson was already known, and there was a very famous bone marrow.
Sure.
I'm blanking on the name of it, but there was a big bone marrow person, at least. See, Texas is just right here. It's like in our back door.
That's right.
So I always think that Texans and northern Mexico is the same thing. They have boots, and then we have boots. We have horses. They have pickup trucks, and
Yeah.
and they have hats and baseball caps, and it's the same thing
Right.
here and there. But so, what are the major programs were at that time in the U.S. or why London?
Well, there were many major programs in the U.S. that I could have gone to. In fact, as a medical student in 1982, I did my rotation at San Francisco General Hospital. Dr. Stephen Embry, who is a very preeminent hematologist, and Paul Volberding. And that was right at the turn of the HIV. I was there in 1982.
That's
right
HIV.
at the height of that. And so I was totally blown away.
HIV before HIV, probably.
That's right, before we knew what it was. We were
Was,
suited and gowned like we were going to the moon because we didn't know how it was transmitted yet. We had theories about viral transmission, but the agent hadn't been found. So this was very informative for me. I mean, I was very impressed with what was going on, and I realized then also that my training in Minnesota was good because I did better than many of their students on things like myelodysplasia. So I was going to go, why did I go to London? First off, it's a good bone marrow transplant center, Ted Gordon Smith and Jill Howes. But second, I'd like adventure. So I wanted to go, I'd rather go work for free there than go to Texas.
Sure, of course.
Okay. So because every weekend I started a project studying bone marrow transplantation for aplastic anemia. Okay, so that's bone marrow failure. And one of the things we observed was that as they were withdrawing cyclosporin, the immunosuppressant, some of those patients had a late graft failure and then regenerated their own marrow. And they couldn't study the marrow very well because they didn't have markers. So if you were sex matched, so a boy for a boy, a girl for a girl, or an ABO matched, so blood type matched, there was no way to tell whose cells were growing in that individual. And in contrast to bone marrow transplantation for leukemia, where the original marrow coming back is essentially fatal, for aplastic anemia, one of the main treatments is actually profound immune suppression. And there's nothing more profound than a bone marrow transplant. So my project was to study aplastic anemia, looking for autologous recovery in sex and ABO matched patients by using what was then the first forensic DNA probes.
So is that what led to your interest in genetics
That's
and prediction?
exactly right. So the kind of opportunism, where you are, what's going on at that time. So that was the first thing, was I started looking at genetic markers. And I even got to see Sir Alec Jeffreys, who is a world-renowned geneticist in Leicester. I took a train to his office. I showed him my southern blots that I was using to do this DNA fingerprinting, as it was called. And he was on my first paper in Blood. So as a first-year fellow in hematology, when I got to Tufts, I had a paper in Blood on bone marrow transplantation, but on the engraftment, showing that we had 6 cases out of 40 that had mixed chimerism. So they had evidence of both the donor and the recipient coexisting in blood. So, but I was fascinated. Then, as part of our research requirement, you all have a requirement to do either public service or research. Well, my requirement was to meet other doctors, and I met Dr. Ted Krantiris. Now, Dr. Krantiris was an oncologist, but a molecular oncologist. He had trained with Jeff Cooper at the Dana-Farber Cancer Institute, and that was the era of tumor genes. So these were oncogenes. And he was doing a project that was looking at the Harvey-RAS oncogene, and that has what's called a variable number of tandem repeat. It's basically a marker at the end of the gene. And he was showing me some southern blots, and I said, I know what those are. I just did that for the last 6 months in London. So I took up in his laboratory, and we were tracking down genes associated with cancer. And I was specifically working on chromosome 11. Now, many of you won't know this, but at that time, the genome had not been cloned. They had not been sequenced.
Yeah, no. That's in the mid-'80s, this time.
So I was on the gene hunt.
So the Human Genome Project started when?
It started in about 1990.
90?
The first draft was published 10 years later in 2000. And that was 10 years to sequence one man's DNA. And it cost $3 billion to sequence one man's DNA. Now, fast forward, and technology has changed. Right now, you can sequence the entire genome in a week for about $1,000. So, what a time a couple decades will make.
So I'm going to digress here for a moment, but since we're talking genetics and this, the Human Genome Project was an initiative of the NIH or of a bunch of doctors with good intention, or academicians or government?
Yeah. Well, it's probably the best analogy is what's going on now. You've heard of the moonshot programs. So Mr. Biden's moonshot initiative. Well, that was essentially the equivalent then. They, in fact, created a new institute, the National Human Genome Research Institute, which was built around this. And they funded a number of centers. It was big funding, big money, trying to make sequencing cheaper. Every base pair counted. And so they tried to make it cheaper. There were about 5 centers that were funded across the United States, and that was to generate the first draft of the human genome. And the job was divided up amongst these various centers.
Yeah. See, we've had a relationship with Baylor College of Medicine for many years. Tom Caskey was so I was going to work with him, but I didn't. But he had, at that time, he was one of the 5 centers for the Human Genome Project. I just remember that.
Yeah, and it's a huge infrastructure investment, but the time that I was working on this, we had to do what we call positional cloning. So you took an area of interest. In this case, Dr. Kronteris was looking at the Harvey-Ras gene on chromosome 11, and I was cloning genes next to it. So it was kind of cool. I cloned a gene. I discovered after sequencing it that it had what's called a leucine zipper. That's for 2 proteins to stick together. And it was near Harvey-Ras, so I called it Hercules, Harvey-Ras leucine zipper. But I found several genes in a row there. We published my first paper in Genomics in 1992 on these genes. And then later, of course, the Human Genome Project, it turns out I worked on that gene for 10 years and still never quite figured out what it does. But I found out later that one of my colleagues at the City of Hope came and said, Jeff, he says, I didn't know you're working on this gene. It says here, the first line of this paper says formerly known as HRC1, and it turns out to be RASF7. So it turned out to be a fundamental gene in human biology that I was able to find at that time. But so again, it was a moment. The moment was on. We were using new genetic tools. I was using a new type of CosMed clone that was actually called a P1 clone, 100 kilobases of DNA in one clone, and that was actually revolutionary at the time.
So maybe for the students, I want just people to understand that we're talking about the career of someone who was trying to cure people with malignancies doing bone marrow transplantation, and now we spend the last 5 or 10 minutes just talking about very fine, complex genetic testing. So, which is going to lead me to the next question. How do you make the move? As I assume that your career at some point changed from saying wanting to treat an individual to maybe trying to conquer the disease or the illness, which is a little different.
So I think a lot of it has to do with what's going on when your mind is wide open. You're reading, as a fellow, you have to read everything, you have to be preparing things all the time. And what was going on when I was in my fellowship? So first I was in heme. I was still taking heme when I got to Tufts University. But P53, the gene P53, was linked to Li-Fraumeni syndrome, which is an inherited syndrome with terrible risk for cancer. Childhood cancers and breast cancer in women, usually in their 20s. It's one of the most severe syndromes we know as a cancer geneticist now. So that was just linked in 1988 to 1990 to P53. The familial polyposis gene was found in 1990. 1990 was the first year that Mary Claire King published on the linkage of chromosome 17 to BRCA1. So she established for the first time this gene existed. The mismatch repair genes that go with Lynch syndrome, colon cancer syndrome, were discovered around 1992 to 1994. So here I was thinking I wanted to be a hematologist and a bone marrow transplanter, but all of this was going on, and I was learning genetic tools that weren't really in common use yet. I changed my career at that moment.
So your first experience with what I would maybe describe as more fundamental basic research was in London.
Yes.
And then you took that here, well, in the U.S.
To Tufts in Boston.
And continue your training, but just exploring more fundamental genetic questions or the association of genes and cancer.
Exactly.
That's a general big topic.
That's right.
Just as a mechanism.
Right.
Not as a way to...
but
there's a difference, right, between perhaps defining a gene as the cancer gene versus the risk of developing or as a prediction.
Right. It's not trivial, and you start to learn things about association and what association and causation. They're very different. But what I did do was that I immediately saw that there was a chance for prevention if we understood who was at high risk. And so my first grant that I wrote was to the American Cancer Society in 1990, and that was, I got funded as a fellow, a career development fellow, to open a hereditary clinic. And so my mentor, and again, mentors are so important, Ted Krontiris, he offered to supplement my salary for $5,000 a year that year because I would have had to take a pay cut to take the grant. And so he said, this will be good for your career development. So I was able to take the grant, and within 2 years, was able to get a clinical investigator award from the NIH for the gene cloning project that I was doing on chromosome 11, and that's a 5-year grant, and it's usually a stepping stone into faculty status. And in fact, in 1992, then I was welcomed to the faculty in medical oncology, but I did something different yet, because BRCA was so much involved in women's cancers, and they were trying to build a research department for gynecologic oncology. I was a medical oncologist on the gynecologic oncology service, and that's where I built my familial cancer clinic.
So, so at that time you were doing clinical medicine and had a basic laboratory at that time, or?
That's right. I've always had a laboratory and a clinical
and
career.
a practice. You've always had both.
Always had both. And so at that time, we were studying the fundamental molecular genetic changes in DNA that go with the cancer, in this case, ovarian cancer. I was back in the pathology lab again because ovarian tumors are huge. So I was there, the pathologists would finish, I would then be carving it away and freezing it and collecting my samples for DNA studies. And I spent my other time in the clinic doing risk assessment for individuals at risk for cancer, and started registry then. In fact, the registry that I still use today, I started then, which was every patient I saw, I got a sample of DNA, a full family pedigree, and then clinical information so that we could study them going forward.
So that was in Boston.
Yes.
And then from there you moved to California.
Well, I did something a little crazy, I would say, in retrospect, which was after having done internal medicine, hematology, and oncology, I then, while a full-time faculty member with my KO8 award, protecting my time, did a full-time clinical genetics fellowship. The Tufts University had just started a new fellowship. They didn't have funding yet to pay the fellows, so I was their inaugural fellow. And I did this on the side while running my lab, running my clinic, and doing a full fellowship. So I was in the neonatal intensive care unit, examining head circumferences on babies and looking at birth defects and developing pattern recognition. So, and that's what genetics is. It's really interesting. It's about pattern recognition. All of these diseases, all the classic learning, the diseases that are all named, right? And that's because there was an astute clinician who looked at it and made these descriptions. All, Virchow's node, all these various observations had a tight clinical correlation. Now we just do a CT scan. But those days you actually had to have some acumen. But that's what genetics was to me.
So, since I'm not sure that everybody understood that the importance of doing laboratory work and clinical work, which is really remarkable to be able to succeed in both areas, is not a very easy thing to do. In fact, I've been told many times that you cannot be a clinician and be very competitive in basic research or fundamental research, let's call it in general. So what motivated you to really drive those two areas and pursue them?
Yeah.
Why not just taking maybe I said, well, I'm just going to concentrate on my basic genetic studies and then don't deal with patients? Or
Well, I think that's a great question. Part of it was a drive to be an entrepreneur, and that is by getting grants and defining my research questions and my activities, because I was bringing in a good portion of my own salary with those grants, that allowed me to do a more diverse set of activities that were really inspiring to me. And so that was a pattern that I started. But you're absolutely right. I was competing against people who were PhD scientists who were doing nothing but working in the lab 100% of the time, yet I still had to take care of patients, write the clinical notes, take care of those family calls and those family meetings, write the orders for their therapies, and it was brutal. It was absolutely brutal. But having done the cross-training in oncology and genetics, I finally found a place, City of Hope, that actually recruited me to come and start their genetics clinic. And I told them, if you want me to do cancer therapy as well, I will do it. I'm qualified. I'm board certified in oncology. But if you want me to build you a program, you will protect my time and I will do nothing but that program. So I was able to write my own job description because I had a unique set of talents. I was able to commit part-time to the laboratory and part-time in my clinic and to create a new program. In fact, Dr. Blazer, who was one of my colleagues who joined me, was a genetic counselor who was actually one of my first hires, second hire for my division, and she subsequently got her doctorate in education because we were doing a lot of things that relate to public health. But as I say, the rest is history. I've been there now 20 years and very proud of the record that we've built with a strong program. We have 3 faculty. We have about 10 clinical research associates. I have 2 people working in my laboratory. And we've continued to, I think, innovate in the laboratory, but not in the way of the hardcore basic science, but really translational science. I'm much more interested in, I mean, I know I have to learn the basic science, the cell biology, but I'm really interested in how do I take the tools that we have and make medicine better, like today, not tomorrow.
Sure. No, I think that's, I mean, it's actually very refreshing to hear that a lot of what we're trying to deal sometimes here in Mexico is where can we be very competitive?
Yeah.
You know, can we compete with places that have tons of millions of dollars, much more than we have? Yeah. What are areas where we can really be creative, innovative, and competitive? And we sort of define areas in translational work as when you look at the spectrum of things that you can do, is that we probably can, so that, which at the end of the day for us, for everybody that really continues to do clinical medicine, it becomes a very important part. So you work in the genetics department today. Is in overall in all areas of cancer, or are you primarily looking at breast cancer or gynecological cancer?
So that's a great question. So it turns out that virtually every adult cancer type has a component that's genetic, okay? Breast cancer was the most ready example because after BRCA1 and BRCA2 were cloned, they were patented, the genes were then commercialized. So beginning in 1996, we've been able to do genetic testing for those genes, but at great expense. And the US is famous for spending more money than it has. So at great expense, we could get those genes tested. Well, over that whole period of time, the technologies are changing. But you look, so most of what we saw was breast and ovarian cancer, plus I'd done extra training in ovarian cancer. But the reality is that colon cancer, equally important. 10%, 5% to 10% of colon cancer is hereditary. So then you look at, there's certain types of brain tumors that would be seen in Leigh-Fermani syndrome. There's even predisposition to leukemia, albeit very rare. So virtually, and even now, there are some germline, meaning inherited susceptibilities to lung cancer. So each of the cancers that we may not have thought had genetic components clearly do to some degree or another. Prostate, another one, that is just emerging with genes that we can tie to prostate cancer predisposition. So I'm interested in essentially all cancers, but the hereditary basis of those cancers and how we can leverage that to identify risk and tailor care.
So, well, I'm not intending to ask a specific in-depth scientific questions. Can you help us to understand the difference between a hereditary form of cancer versus a mutation that arises de novo in a tumor? Because if you look at just genetic mutations, probably the prevalence is much greater than those that are hereditary.
So virtually all cancer is genetic, and that is cells have acquired mutations that have corrupted the blueprint, and that cell behaves badly. So there used to be a show called Men Behaving Badly. Now that's back on the shows again, but all of them are behaving badly. So, so in any event, cells behaving badly. So all cancer is due to a corrupted genome. But the difference is, did you inherit it? So we were born with it, so it was in the germline, came from the egg or the sperm, and then was present in every cell in the body. And in most of those cases, they're what we call autosomal dominant, which means you only need one abnormal copy of the gene. But interestingly, in the tumor, there was a change in the tumor only, where they lost the good copy. So now there's no copies left. And then that's actually become a nidus for therapeutic indexes, windows. So in BRCA, if you are taking a tumor from a woman with a breast cancer that is associated with BRCA mutation, in that tumor, they're BRCA null. The good copy that they were born with from the other parent is gone. The cells are deficient in that, and you can use therapies like poly-ADP ribose polymerase, PARP inhibitors, to great effect, great therapeutic index based on the genetic profile. So there's a good intersection between both acquired and inherited. And in ovarian cancers that have 2 copies abnormal, based both of them in an acquired way, well, they're also responsive to the same drugs. So it turns out to be quite an interesting intersection. So you start out with 1 copy in the germline, but those cells are just fine. But when you lose the other copy, that backup copy, if you will, that's when those cells become genomically unstable and far greater chance of becoming cancerous. And that's really, we try to interfere in that process.
So we spent a little time earlier, and I asked Jeff a question as to why did he become interested in Latin America, and why looking at Hispanic women. And so maybe I'd like for you to address that point. What was so interesting about the composition of the cancer or the populations that you were studying, just maybe because you were in the LA area, or or does it has a particular interest? Was there a question before that would make you study specifically that group of patients? And
so I think, you know, I've thought a bit more about the question as well since we talked a little bit ago. It actually goes to some fundamental things we learn as physicians. Some of our core learning, justice, disparities, doing well for people. You know, our motivations, if I wanted to earn money, I could have been a banker or done something else, and I could play golf every day. You know, I mean, that would have been what I could have done. But instead, the fundamental things we learn about our bioethics are really helping other people. And so part of that is justice and economic justice. So I guess you become socially liberal often as a physician, okay? Which is, that's not going on.
Depending. I know many that are really not quite like that.
I know, but I am.
In academic medicine, probably more so.
Academic medicine, yes. That's right.
So private plastic surgeons, probably not.
That's right. So those traits those traits in academic medicine are favored, yes. Right? So what we did was we looked at fundamental issues. By the way, I ended up in California because first off, I was happy to go there. Great opportunity. But I also, when I was 20 years old, living in Minnesota, I had an opportunity to go work as a gardener for some people in Malibu. And so I lived on the Coast Highway for a summer, hitchhiked up and down the coast, because those days you could actually hitchhike, and worked as a gardener in California. So I thought it was nice to come back there again.
From Minneapolis, I guess, or
it was
winter time.
That's right. So in any event, I think that what we did is I started, one of the things is you collaborate. The other things that are important to careers in academia are collaboration and trust. Trust with the people you're going to work with, and collaboration to make things happen together, because again, any one of us can't do this alone. And so one of my colleagues, Nancy Feldman, who is the head of oncology at one of the safety net hospitals in San Fernando Valley in Los Angeles. This is our county hospital, the equivalent of the Seguro Popular, only in LA, and Medicaid is the term, and Medi-Cal is our version of that insurance. Well, she told me, she says, Jeff, she says, we're dying out here. We are having women who are 32 years old, who have stage 3 breast cancer, and they have a family history of breast cancer, and they weren't even getting care despite that, and we can't get genetic testing because the younger age and all of that is very provocative for the likelihood of genetic predisposition. So they couldn't get access to testing. Medicaid wasn't paying for it. And so, and the service population at that hospital was about 80% Latino. So this was a need, and Nancy had appealed to me, and we had the tools because we had genetic counselors. I had my laboratory so we could try things different ways, and we worked on philanthropy. And so we went and started a free clinic there and started taking care of these patients. Really an effort to address a disparity, reaching out and collaborating with a colleague. But along the way, I wouldn't say we were rewarded, we were simply observant, which was because these women were disproportionately underserved. Okay, so in the US, certainly the Latino population is growing very quickly, but if you take as a proportion of that population, there are more that are underserved than the majority populations. So in this case, we were taking care of women that nobody else was doing the testing because it was too expensive. And so I learned how to do behavioral research to get funding from Komen to pay for the genetic testing. And so we did everything we could to get the testing paid for. And along the way, started finding out that some of these mutations didn't happen randomly. They were occurring in patterns. And I would find same women from the same parts of Mexico with the same mutation, but they were unrelated to one another because we had multi-generation pedigrees already sussed out, and there was no connection between them. In fact, one of the first mutations, we didn't talk about this, but one of the first mutations we found, that I saw it in 4 successive families, unrelated to one another, multi-generational Catholics, and it turns out to be the most common Jewish mutation. Really? So 185 del AG, we found it, and I said, well, that's interesting. And
Way back then.
This is back in 2005. And so I actually took my West Los Angeles Jewish population that I had individuals with that same mutation. We compared the chromosomes for my Latinas and the West LA Jews. They shared the same chromosome. So it proved the genetic connectedness to the Jews. Where does that come from? The Spanish Inquisition and the forced expulsion of Jews from Spain. They were Sephardic Jews.
Okay, so these Hispanic women were less Indian or less?
Yes, they're European mostly.
More okay.
European Spanish ancestry, or but they were. But it was the anthropology, the history
that's interesting.
that started to drive me with great interest. Was that idea that I started to learn about things that I hadn't paid much attention to in school. And so it turns out that, in fact, we firmly linked, we're the first ones to link that mutation in that population. So in other words, there was a much greater diaspora to the New World of Jews from Spain and Portugal than had ever been appreciated. We all knew about conversos and those that came across, and in those days you could work on a boat, but you couldn't be a passenger on the boat unless you were a Catholic. But these were multi-generational Catholic families, and if you look at Catholicism as it's practiced in Mexico, there are more Old Testament rituals than there are in Minnesota, if I went to a Catholic church there. And I believe that's some of the integration of Jewish culture into that. So we found that there's a much greater diaspora. And then the second thing we found was that when you do sequencing, so you're doing a spell check of all the genes, of all the sequence of the gene, well, it turns out that certain types of mutations, a piece of the gene is missing rather than simply misspelled. And that type required a different technical approach, which wasn't readily available. So in 2006, we took 78 patients who were negative by BRCA but looked suspicious. We applied what was then a brand new technique, and I was collaborating then with Myriad Genetics. And we found on the first gel, there were 4 patients who had the same large rearrangement mutation, not detectable by sequencing. And I said, well, this is unusual. These are unrelated families, the same one. This is the edge of an iceberg. This is something important. And so we published in 2007 on this. We cloned and sequenced the breakpoints. And then what I did was I changed that test from a multi-$100 test. Once we cloned the breakpoints, we designed an assay with PCR that costs about $1. So now we could screen large numbers of people for that mutation. And so we started picking off that mutation among lots of other people. We then, when we had 20 families with the same mutation, all of them unrelated, we did that same haplotyping. So that's the beauty of having your own lab. You get to ask the question and then do the work. So we said, how long ago did this happen? There's a way to do that. You can do sort of the equivalent of carbon dating, but in genetics, you're doing haplotyping. And we found out that this mutation was 74 generations old. Well, an average generational age of about 20 years. You're talking almost 1,500 years ago that this originated. We had never observed it in anybody who didn't have Mexican ancestry. In fact, we found it in Venezuela, but they were Mexican. And so that we found out that they were from Mexico. So that's one thing. It was 1,500 years old, and that's 1,000 years before the Spaniards ever arrived. Okay? So it wasn't that type of mutation.
Didn't come from Europe.
Didn't come from Europe. And we actually, many of the other mutations we saw repeatedly were from Spain and from Europe. So there are other mutations that are frequent, and they almost all trace back to the Spaniards.
So if these mutations existed back then,
Yes.
was women dying of breast cancer and people didn't know back then? Or are there epigenetic factors that will make these genes express or be more fatal?
Yeah.
Or what's
Well,
the-
if you go
or
back
people-
500 years,
No
they,
one-
they died of heart disease and cholera. So
Right,
they didn't
no,
live long enough
so
to
they-
get their cancers.
Sure.
Yeah.
But so are there? No, that's interesting. It's like I feel like I'm NCIS or what's
Yeah.
the show? Like if they look at you know, mummies or bodies that were discovered in the Ice Age or whatever, is there any evidence of breast cancer back, say, 500, 1,000 years ago?
Well,
Is there any data that exists in
yeah.
archaeological pieces of
Well,
material that?
I haven't seen anybody identify a BRCA mutation in some kind of archaeologic find. Some of the mutations we know are at least 1,000 years old or 1,500 years old. That's the ballpark of most of the oldest ones that I'm aware of. Now, the other thing about the one that we found that was only in people of Mexican ancestry was that we were able to take other markers, and they've done work here at the Genome Institute in Mexico City on this as well, and other places in Mexico, to look at what was the component of the individual. How much European, how much African, and how much Amerindian or Indigenous American. And we showed that in the individuals who had this large rearrangement, they had a statistically greater proportion of Amerindian ancestry, which correlated to us with how old it was.
Now, and this is the rearrangement that's more
Yes.
likely to cause triple negative and very aggressive form of breast cancer.
That's right, and ovarian cancer. So in fact, we found nearly 30% of ovarian cancers in my work with Dr. Villarreal in Mexico City at INCAN. She had a study of ovarian cancers, and among them, 28% had a mutation. Of those, over 1/3 were that one mutation.
So let me, is the incidence of breast cancer increasing over time? Or are we just more aware of it? Because now I hear everywhere breast cancer.
Yeah.
And there is, of course, a very active group of people that promote it, and everybody knows that there is a problem with breast cancer in Mexico, in the U.S. But is the incidence really increasing, or is the same?
I think it's difficult because there's two things going on. One is, if you're not applying, first off, as you know, when we applied mammography across whole populations, we started finding very early tumors in ductal carcinoma in situ and things that may never have manifested clinically. So there was a peak of incidence but if you really look at invasive breast cancer only, there are some social trends that are increasing frequency. So for example, what we were talking about earlier in terms of metabolic syndrome and obesity. So there's no question that obesity increases post-menopausal breast cancer risk. Turns out it doesn't increase it premenopausally. And so the genetics are probably still operative for the young cases, but that as you age, there's absolutely multiple modifiers.
And the postmenopausal has different genetic predisposition.
That's right. And second, we found, as we've already known, there are many reproductive patterns that can increase breast cancer risk slightly. And it turns out the same factors that increase risk in average women increase risk in BRCA carriers. So what's happened? We're having babies later. We're having less babies. More ovarian cancer. Okay? More breast cancer. And so these are social trends as well as biologic trends. Sure. So there's a big intersection. But you know what that tells me is that tells me that we can manipulate some of those systems, be they hormonal or otherwise, to change risk. So in fact, we published a study in 2007 where I was working with Malcolm Pike, who's at USC. And he's a mathematician, that's what he calls himself. But he's really a fantastic epidemiologist. And he was studying hormonal effects, and he showed that the rate of rise of breast cancer during the premenopausal years, so from age 30 to age 40. So at age 30, it's 1 in 2,000. At age 40, it's 1 in 200. At age 50, it's 1 in 50. At age 60, it's about 1 in 15. So the rate of rise, it went from a 2,000 to 200. That's a tenfold change in the decade from 30 to 40. The absolute incidence was low, but the rate of rise was very steep. Then, if you take a woman who's had her ovaries removed prematurely, prior to natural menopause, the curve drops. And if you follow that person out for the rest of their life, they have a 50% reduction in breast cancer risk. Okay? So the premature menopause. Now, but who wants to be in menopause early, right? So trust me, and I'm a guy, so I can tell you, there's a reason why I like my patients to actually like me. So any event, what we said was, well, couldn't we do this medicinally? And so Malcolm Pike they'd done something called Balance, which was they gave a gonadotropin-releasing hormone agonist, so think Lupron, turned off the ovaries, and those women, they treat endometriosis that way. They treat various things. Precocious puberty, they stopped that with Lupron. But then the woman would have menopausal symptoms, so they gave back a low dose of estrogen, mimicking what we give postmenopausally, about 50 picograms per mil. Now it turns out that by dialing down that, if you just take the area under the curve, what you're missing is the peak of estrogen at ovulation and at the menstrual phase. And what you have is a lower mean exposure to ovarian hormones over the month. And so what we then studied was, what are the other risk factors for breast cancer? Breast density. So we showed that if we gave these women Lupron plus low-dose add-back hormones, we could reduce their breast density while they're premenopausal, and maybe this would be better than oral contraceptives. And oral contraceptives just did a meta-analysis showing there may be some slight increased risk for breast cancer. Now, pregnancy has its own hazards, but there is it may not be neutral in terms of breast cancer risk. So the idea was, can we do this in BRCA carriers? So we took women between 21 and 35 years old. We gave them a nasal spray so they didn't have to have injections. So we gave them a gonadotropin-releasing hormone agonist, estrogen and testosterone at a low level. They didn't have hot flashes. Their bones stayed stable. They didn't have any endometrial hyperplasia, and we reduced their their breast density by 30% in 1 year. That would make their mammograms easier to read, and we would predict would lower their breast cancer risk. So in a way, we were emulating the benefit of the oophorectomy while preserving fertility. And so that's why I say is you take advantage of the epidemiology to try and get at prevention.
So once you have babies, then why do they need the ovaries? It's only there to give you cancer.
Well, I'd be very careful to be sensitive about this topic.
No, I understand that, but I guess, is there anything good that comes out of the ovaries after you use them for?
Some people think that there is some secret sauce. Okay, so that what hormones? So the ovaries postmenopause, they make a little bit of testosterone. Obviously, the gonadotropins go up because they're trying to stimulate the ovaries that aren't no longer producing anything. My personal bias is that they don't serve a purpose. That you can remove them. That you can give a woman back low-dose add-back hormones, and she will be perfectly happy. Bone density will be stable. Problem is that there is some competing epidemiology that suggests premature menopause, so premature oophorectomy, may have increased all-cause mortality in the general population. In the BRCA population, we showed that it actually reduced all-cause mortality, which meant to me that they weren't dying of heart disease prematurely. They weren't, all the things that we gave them hormones for. So I believe there's a way to be smart about this.
Very good. So I'm going to change a little bit of course here of the conversation, and a lot of the work that you've done is funded by the NIH or by private funding mechanisms, or by, what would you say be the largest amount of funding that you have for these population genetic studies? And
so we'll take money.
I'm going to ask you another question right after that.
We'll take money from almost anyone.
Of course.
Okay. And City of Hope has a long and rich history of philanthropy. They were a charity hospital to start with. They first addressed tuberculosis, and so they've been around for 100 years. And they started out because a Jewish shopkeeper lost his livelihood because of tuberculosis. So they started a working men's fund. So it was self-funded, and people used to get free care there. So if you got admitted to the City of Hope, you never received a bill, despite commercial medicine being what it was. They changed in about 1970. A little earlier than that, to focus on cancer and diabetes. But in any event, so the point is that they are lots of philanthropy, which is great, but I've had equal measure of NIH funding, which, by the way, we've leveraged educational funding, which is a different type of funding that the NIH provides. NIH funding, foundations like the American Cancer Society, the Breast Cancer Research Foundation, Avon. I've been funded by all three. Currently funded also by the Leaf-Remeni Syndrome Association, which is a very small foundation, but they're helping us to support a data coordinator for a data coordinating center role that we have for Leaf-Remeni syndrome. So each of these things, we would really try to be as innovative as we can and try to find the right grant to the right project.
So the other question is, I was expecting to hear the NIH was a significant part of your research, and the question that I was trying to get at is, with the new president has made waves everywhere in the world, not only in America, but everywhere you go. It's like there is no individual that can think that has no comments either. I'm not going to make a statement or position here, but funding to do a lot of this work that requires risk, and it doesn't lead into a very concrete idea tomorrow, and perhaps that benefits in this particular, which is what I was asking the question, that you're trying to do work today that would benefit Latin America more so than America. And in this concept of making America great and don't care about anybody else, is the NIH funding changing dramatically in terms of the projects? A project like this, where you say, I want to discover a gene so that I can help the women of South America not to have breast cancer. Is there a great risk of funding for studies like this be halted or be?
I think if you ask the right scientific questions, you can still get funded. In fact, one of my colleagues, Susan Newhausen, is a molecular biologist, and she got a grant to study whole exomes, so the entire expressed genome, in Hispanics, so Latinos, who were BRCA negative in my clinic. So because we have our registry, we have literally thousands that we've tested that were negative. We then looked at entire exomes, and that was funded by the NIH as an R01. On the other hand, and again, the goal was to find genes that were relevant to the Latino population. But don't forget, it serves the US population. They're still the fastest growing population in the US. In California, this year, with the last census, there is no majority population any longer. So there is no majority population in California. So that's our life, that's our world. And so I'm encouraging my sons to learn Spanish. My biggest problem has been that I'm Spanish impaired. The good news is that I have people like Rosa Mejia and Kathleen Blazer, who are both quite proficient or bilingual and bicultural, who then help me, so they're my crutch. So in fact, I bought Rosetta Stone, Latin American Spanish, but I found out that you actually have to open the box if you want to learn. So I have had it sitting on my desk, and because I've been so busy trying to do so many things, run the lab, run the clinic, that I haven't actually started to learn it. I learned French, which is, I took care of some Haitians, but that was the utility of my French.
So since we talk about that, there was a question here that I think I got a glance of it, that one of the students asked, in your interactions with people from Mexico, how, don't talk about Cynthia, but what have you found about the not the training, but the ability to interact with physicians from Mexico in terms of collaborations or research or?
I think it's not just interactions with clinicians and scientists from Mexico, but rather Latino people in general, because I think what we have to learn about our clinic was that they are the most grateful. When we provided our free clinic, I am rewarded every day by their gratitude. They are the most grateful, and in contrast to research in disparity populations in the US, Tuskegee and all of the historical mistrust of authority, that's not the case in the Latino population. Once they recognize that we are there to help their families, don't forget that genetics is the truest family medicine, okay? So when those women realize that we're there to help them learn about their risk and help their families avoid that risk, they're there, they're with us. And they are the most vociferous and generous in their gratitude of almost any of my patients. When there was a bus strike in Los Angeles, some of those patients walked 5 or 6 miles to attend their clinic. My insured patients never did that. So I'm impressed that, first off, there's a gratitude and a sense of, they know that there's also respect for authority. So if we have developed a position of trust, we don't violate that trust. Those are the principles of how we conduct ourselves there. And the same applies to how I conduct myself in science in collaborations. find trust, collaboration, respecto. So those things, I think, are the key ingredients that have made it very gratifying. Further, we've been tried to be generous with what we can do with our training. So that's where Dr. Villarreal, I know you told me not to talk about her, but and Dione and others who have come to train with us in our course that Dr. Blazer helps to direct. That's a 100-hour course. It's a huge commitment. Because I was interested in Latino health, both in the US and in Latin America itself, we started to think about dissemination and implementation science. So how do you help catalyze a new practice, a new technology in practice? It's difficult to integrate these things. And so we have now, that's our new area of research, is how do we use education and then support from the laboratory side to help implement long before it's being recognized at the government level as necessary care. And everybody thinks that genetics is extravagant care. It's care that is only for those who have lots of money. And the actual fact is that the health system can't afford not to do it.
So does Medicaid pay for genetic testing?
It finally does now. It was about 3 or 4 years now that we've been able to. But mind you, that was 17 years after it was first approved for commercial funding. So private insurance has paid for it for many years. About 5 or 6 years ago, probably 7 years ago, Medicare started paying. And Medicaid is state by state. I believe there are still some states in the US that don't pay for testing. So this is still a mission, something we're working on. And by the way, you're talking about our fearless leader. You know, the way I like to think about our work in Latin America is we're building bridges, not walls.
Sure. No, I didn't really go into that specific point, but in some way.
I don't mind going there.
No, but it's like with all I mean, the U.S. really provides leadership in many different ways, and certainly in science has provided leadership for many, many years.
Right.
And really my question was more towards the fact that will we see some major cuts in funding when the benefits will be universal rather than more protective to your own benefit?
I think there's two things. First off, one thing I've learned, and this is a hard lesson for a clinician scientist, is it's hard to get translational research funded because on the surface of it, it's obvious. We should do testing for these people and we should provide prevention. It's obvious. We know it works because we've done it in insured populations. So how do we do it and how do we implement is a challenge in and of itself, but it's obvious. So that's not sexy enough for the reviewers. So in fact, NIH funding has been hard to get for translational work for a long time. Foundations, on the other hand, have a bit more of a humanitarian angle to it. Just helping people may be worthwhile for some of them. They want you to advance science, but helping people is part of it. When I've had NIH funding, and we're going to train clinicians from Mexico or from South America to come up, we had to use a US carrier. They couldn't fly on a different airline. We had trouble to reimburse them. We had to do special, and this is before Trump. So even before him, don't forget there were Republicans in Congress and others who would say, not in my backyard, right? So we had to, we've always had to navigate that process. But the way we're going to justify it is that these are the families of the patients we take care of. What we learned there, we can apply here. And somebody we just had recently work with us, Yanin Chavari, who's a medical oncologist. She's one of your stars, and she's at Nutrition in Mexico City. She and Cynthia remind me of each other in the sense of they're both, I think, rising stars, very smart, very bright, and able to do so much. Anyway, she spent a year with us, and her husband Enrique was studying old people. So he was working with Arthur Hurry at our shop, and in this time we talked about, but he came up with this term. He says, you know, there's this term of reverse engineering. So if we can help make it happen in a low resource setting, then we're going to know how to do it cheaply in the US for similar populations, disparities populations. And so that's what we're going to do for grantsmanship. We're going to take that back to the table and say, what are we learning from our process? We're not just helping people in Latin America. We're learning how to do it lean, and that will serve everybody in the US.
So let me ask you a final question, and then we'll take a few from those that have been posted here. When you have information in a particular group of patients, in a particular racial population, how difficult is it from a bioethical point of view to try to extend it to others, and how do you make, will that make at least some groups of people, the perception that there are races that are better than others because they have more or less mutations, or how do you deal with that type of information?
That's a great question.
Yeah.
And in fact, there's whole areas of science, or at least health sciences and behavioral science, that look at the concept of stigma. Okay, so the stigma of disease, really. But there are, I like to say in genetics, there is nobody who's got a perfect genome. If you do a whole genome analysis or whole exome analysis, everybody has at least one or two recessive disorders that they are carriers of. Even cystic fibrosis is about 1% of the population carry it, but you just have to have two carriers, and then the 1 in 4 chance of an affected child before you start tracking backward. So there is nobody who's got a perfect genome. And if it's not predisposition to cancer, it may be heart disease. As you know, the genetics of heart disease are becoming ever more illuminating. And even lung cancer. Tobacco is a huge factor, but predisposition to lung cancer. So I don't think that there's any specific group of people, but what we did have a lot of pushback on was, what about these other countries, and what about our own clinics in the county hospital? You're going to go find risk, and these individuals aren't going to get the care they need. And so I kind of rebel against that. Should they be ignorant of their risk because we can't provide their care, or do I inform them and enable them to at least try to get that care, and then try to force the changes necessary to provide compassionate care, and do it by learning cost effectiveness. So policymakers don't want to know about compassion. They might not want bad publicity, but they don't want to know about compassion. They want to know about money. And so if we can make the case that it's economically in their interest, because we're going to save lives and reduce healthcare costs, there's a incremental cost, and then there's cost savings, and both have to happen. There is anything you do extra is money, but you need to have benefit from that. So part of our future is showing that it is cost effective, that it will actually give a return in both health and in cost.
So since we've talked about Cynthia, I'm going to ask Cynthia, maybe Cynthia, come over here, because I want you to make a comment. And we talk about major areas that affect direct patient care, maybe research, but the implications of genetic testing in large populations are very significant. Can you maybe just give us a comment? What happens in Mexico? Do we actually use genetic testing on a regular basis? Do we act on the information, or do we do sometimes testing and we have no resources to act on what we find? Can you just maybe give us a general comment for everyone? Because I think we went into very significant detail in an area that's very potentially, I think it's very applicable for for medicine, not only, we're talking about breast cancer today maybe, but I think this is going to be the way medicine is going to change in the future.
So what I can say is that in Mexico, we are maybe 20 years behind on what they're doing in other parts of the US. So in general, our patients, at least our breast cancer patients, and every cancer patient does not have access to genetic testing in Mexico, either by Seguro Popular, IMSS, ISSSTE, or whatever. Even the private patients cannot get access to the testing because the insurance companies do not pay for that at this moment. So virtually genetic testing does not happen in Mexico.
So that everybody, we're all on the same page, give us an example of what would you do with an information of a particular patient where you have a genetic test that tells you the risk of cancer is such and such. What would you do, or how would you extend that information to other members of the family?
So there's nothing more preventive than knowing that a patient has a genetic mutation, and you can do preventive measures with that. Either getting their ovaries removed or their breasts removed, or tested more frequently with MRIs and mammographies, and not only extending that benefit for the patient itself, but for the family, and that can reduce cancers in those
So
patients.
why wouldn't we just do genetic testing instead of mammograms?
Well,
Or is that the next wave of?
it's a great question. I will tell you this, is that, I think it's a great question. So the issue here is that, so mammography, I understand, is a covered benefit under Seguro Popular. However, I'm aware of a statistic that I heard from at least one person, only 19% of women get routine mammography. And so we have a disconnect. And further, I understand that sometimes they may not be read as quickly as they should be, and that the equipment may break down because of the system of regional grants for support of infrastructure. And so you have to have somebody who's interested in this. But if at least we got it to work for these individuals at highest risk, and I'm sure that with this beautiful hospital, this is like coming to, this is better than our hotel, by the way. So this beautiful hospital, and I'm just very struck by the amazing place that you have here, you may well have access to breast MRI on a routine basis. I don't even dream that that's going to be possible for the mass of the population. It's extraordinarily expensive. It's at least 10 or 15 times the cost of a mammogram, but it's also so much more efficient, so much better. But even if we can't get a MRI, if we can get a mammogram and a doctor's exam and the patient's doing self-exam, we convert the 60% of women who are presenting with stage 3 breast cancer into stage 1 or 2. So even if that's all we can do is get them to stage 2, you know, Cynthia can tell you that's a huge change in mortality, huge survivorship, and if we prevent the ovarian cancers that go with that, we don't even have to achieve perfection. It just has to be good.
So I'm going to close with one final question, is that to actually make all these changes, you have the knowledge, you can do the testing, but there is a major gap here. How do we create policy that really is, that's reasonable, that's intelligent? And I think, are you involved in political action groups, or and how do we make Cynthia be more active in that aspect here in Mexico? Because I think that for us to really make a change, it's not going to be about a new test. Because how do you translate this into public action?
I would like just to make a short comment for these students. So Dr. Weitzel and I met about 7 or 8 years ago. It was 2011 when I was coming just back to Mexico after my fellowship in Toronto. And he reached to me because he wanted to make collaborations with Mexican physicians. So I had interest too in genetics and breast cancer, obviously, and we met and we started a collaboration. So everything started with a collaboration, and as Dr. Weitzel said, it was trust and confidence, and that's when we started working, and since then we have made a very good friendship, and we have been doing a lot of things together. And what I can say now is that we have tested around 800 patients and around 160 from TecSalud under the leadership of Dr. Dione Aguilar, who is our leader in the Genetic Cancer Institute here in TecSalud. So,
I guess I'm asking.
I'll get to this.
I wanted to mention that.
Okay. We have a plan.
And with that, we're making the point that when we make available these tests through research, because it has been through research, then we're now making the evidence so we can make politics.
And Cynthia, let me go beyond that, because I think when we first were working together, you were working at INCAN. And so I met Alejandro Mojar.
Stole her from INCAN.
That's right, you did. And I actually cautioned her about that, but you know, so you're gained for sure. But Alejandro Mojar, you probably know Dr. Mojar. So he has been entrusted, my understanding is, and we've been, because of our work together and what he saw we developed, and so he was very supportive. He's been a colleague, a friend. He's been charged with creating registries from the government perspective, registries for cancer, because you have to have a registry to be able to document the problem and the statistics, and then to know when you've made a change. So he's been charged with that, and so working on the National Cancer Plan. And so we feel completely blessed if we have a dialogue or a voice in that process. So I am merely here to support Cynthia and to help provide the tools, any tools we can, and case history from the US to here, but the idea is that we do feel like we do need to change policy, and we will do it with evidence and good outcomes, working with my colleagues, Yanine Javary, with Cynthia, and looking at the clinical outcomes. So did the patients who got tested do the right thing? So if you build it, will they come? If they come, will they learn? If they learn, will they do the right thing? And if they do the right thing, will they live longer and have less cancer? And I believe we have evidence for that entire arc.
No, I think, and I push you, and I'm actually trying to convince you that you have an opportunity to maybe actively get involved in a policy, because Mexico, it's a maternal state. The mothers are everything in Mexico, right? And this illness affects young women and young mothers, and I think that there is an opportunity to use this as an example of how we can actually push and advance healthcare that's more equitable for everybody. Because if you have money here, you have access to everything. But your women that are dying, as everyone, many more that have no access to anything. So I think that there is a good opportunity. Just like, you know, infant mortality here is watched very carefully.
Yeah.
If a baby dies that should not die, it's like the country stops, and then everybody, health minister will come in and attack, and then, so this would be not that different. I think that people need to be more aware of it. So I guess that's what I was pushing.
I want to make one factual point. So you said women, right? Fully half of all hereditary breast cancer comes from dad.
Yes.
Okay? And nope, seriously, this is an important point.
Men are responsible for the problem.
For half of the problem. But the point is, so we use this also to help educate, because many people don't, you know, they say, what? We only told to worry about mom's side of the family. Dad's side is equally important, and now we're learning that men have increased risk for breast cancer, for prostate cancer, that's clinically actionable. And so we try to make this more important to both sides of the coin, and it has better chance of success as well. But I agree with you entirely. Now, from my perspective, I would expect Cynthia to be politically active and to be a leader. I know she is, and she has that potential. We always run the risk of being the carpetbagger coming from the U.S. to say how it should be done.
No, I understand,
You know,
sure.
So I purposely would take a backseat to be able to be as supportive as we can, but obviously the voice needs to be.
Very good. I think we're running out of time, and I was scanning a few of the questions, but I think we addressed many of the different points that are relevant. I think that I like maybe to leave everybody with the idea of the combination of science and to trying to ask a question beyond the care of an individual will perhaps give you equal or even more satisfaction than the great benefit that we all get taking care of patients that we see on an individual basis, but coming up with the treatment strategies or population-based analysis that will help you take care of a broader group of patients is also equally or greatly satisfying. And so I think that we will close with this. Jeff, I appreciate your time and all the work and help that you've contributed to our growth in the oncology department here at TecSalud.
It's my honor.
Gracias.